Hello, everyone. My name is Dr. Sandra Jan. I'm an adjunct clinical affiliate at the University of Texas at Austin School of Nursing and a psychotherapist in private practice in Austin, Texas. I'm also a proud member of the Psych Congress Steering Committee and our Psych Congress family. We hope everyone is doing well and staying healthy during these really uncertain times. I'm glad you've joined us for this 4-part video series addressing tardive dyskinesia and the challenges of coping during COVID-19. I'm very excited about our guest expert today, Dr. Gus Alva. Dr. Alva is well known to Psych Congress, and he's a respected member of our faculty. So as we begin our series today, we're going to be discussing the top 3 challenges associated with delivering healthcare to patients with or at risk of developing TD during the COVID-19 pandemic. This program is approved for 0.25 continuing education credit, and the series is supported by educational grants from Teva Pharmaceuticals and Neurocrine Biosciences. Before we get started, it is my absolute pleasure to introduce Dr. Gus Alva, who is a distinguished fellow of the American Psychiatric Association and is an assistant professor at UC Riverside Medical School, Department of Neuroscience, as well as medical director, ATP Clinical Research. Thank you for joining us today, Gus.
Thank you so much, Sandra. It's a pleasure being here, and it's an honor. Thank you.
You know, Gus, in considering this pandemic, all the changes, the adjustments we've made, I keep thinking about the importance of maintaining physical distancing. And so I'm wondering, when you're examining patients with TD, how are you going about maintaining that physical distance?
Maintaining physical distance in the face of a pandemic is of critical importance, but that can sometimes throw off a clinician, make them feel like I'm not going to be able to do an appropriate diagnosis or assessment on someone in whom I suspect might have tardive dyskinesia, since I'm going to be limited by lacking that physical proximity to them. Now, I know that many clinics, including our own, still have some patients that come in. But obviously, that number of individuals has actually needed to be reduced significantly. We don't want a situation where people are crowding. We don't want people where they're, converging in one space, because we know that this virus will propagate when there's a limited amount of space and people are breathing the same air. So in trying to limit that, what we've shifted towards is more of a telemedicine encounter. And one would think that a venue like what we're doing right now is not going to be conducive in being able to come up with a diagnosis of tardive dyskinesia, or even in following up with someone that has a diagnosis of tardive dyskinesia. In other words, if I've recognized that someone has tardive dyskinesia and I'm treating them with a VMAT2 inhibitor, which is the FDA-approved way of treating tardive dyskinesia and the only FDA-approved way of actually getting this done and accomplished, how do I make sure that I'm maximizing on what I'm doing for my patient? Well, I would argue that, this type of a setting provides an even easier way of assessing individuals. If we think of the abnormal involuntary movement scale, which is the formal way of, gauging the severity of movements associated with tardive dyskinesia, there's 7 items there. 4 out of those 7 items are easy to recognize just based on what you and I are doing right now, because we're looking at the neck up. And if you think of item 1, muscles of facial expression, if you were to draw a line across my cheeks and consider up, that would be item 1. If you were to take a look at the additional items, including, again, muscles associated with the area around your buccal region, that's easy to take a look at. And if you were to consider the jaw, whether it moves side to side, front to back, or has a chewing type of emotion, or if all of a sudden I was puffing my cheeks, you'd be able to pick that up pretty easily. In addition to that, if all of a sudden my tongue was coming out of my mouth and thrusting and so on, that'd be easy to pick up. So just with that, we're able to get a fair amount of information without someone necessarily thinking that they're being observed. So it's kind of a nice thing, right? Having the opportunity of a filter that's artificial, but very useful for us. So this is actually a win for clinicians. We have a way in which we don't make the patient feel embarrassed that we're observing them, but we're actually tracking them in as close of a manner as possible. You know what I mean?
Absolutely. I love what you said, that telemedicine really offers us a way to promote physical distancing. So it's a win-win for us as well as our patients. So as we just discussed, Gus, physical distancing really is a challenge, both a challenge and an opportunity that we as clinicians deal with. But what about other things related to conducting an assessment? I mean, especially when we're not able to meet with our patients in person. I'm thinking about enlisting the help of family members, other caregivers.
Yeah.
What challenges have you faced in your practice doing these assessments? Maybe best practices that you could recommend to our viewers?
You bet, Sandra. Great points. Sometimes we're faced with different challenges, including lacking, say, a family member or caregiver or an associate that can give us additional feedback as to what's happening with the patient. But one thing that I've found, and a best practice scenario would be, maybe enlisting someone else to help out with the technical issues associated with the form that we're going to be utilizing. So if someone's not adroit at, wielding a computer or a tablet, the pretext of someone else being there to help out with that. And oftentimes, many of our patients have sheltered in place with other family members. So that's oftentimes a nice linkage right there of someone that also has an understanding of the individual's history. I'll give you an example in case. I had a young man who, interestingly enough, had suffered with anxiety and depression quite a long time. Many of our patients will oftentimes forget a fair amount of their clinical history, but this young man's father obviously had gone through this journey of, different problems with his son. And he was able to, regale me with the different medicines that his son had been exposed to. Among those were D2 blocking medicines that many clinicians had actually missed. And the main feature and main presentation that this young man was having was that he was gasping for air and felt like he was suffocating at night, and he was grunting quite a bit. Turned out he had tardive dyskinesia, and it was affecting him internally in such a way that he was having horrific laryngospasm. Obviously, having then curtailed additional tidbits of information from the father helped me then figure out, what exactly this young man had, and why so many clinicians had failed to actually figure out what was going on with him. Treating him accordingly then with a VMAT2 inhibitor literally changed this young man's life, and actually his quality of life improved tremendously. But that was because of the fact that I had ancillary information that was being brought about by a family member. And I think that as clinicians, we can always draw on things like that.
Gus, sadly, this pandemic has been a challenge for clinicians caring for patients with TD. It's really disrupted our usual treatment teams. You mentioned that earlier. We don't have easy and ready access to all of the players on our patients' treatment teams like we did before COVID-19. How have you seen this play out in your practice, and how have you overcome the challenge?
Sandra, those are great points. The disruption that COVID has brought about has been of such an extent and such calamity in many cases that we've really had to shift gears in trying to link our patients as best as possible to everything, from encounters and We shifted gears from seeing people physically in the same office to going to more of a remote platform. That in and of itself has created some interesting challenges. Some patients, for example, my patients with underlying psychosis are quite comfortable with this medium. They weren't necessarily going out and socializing a whole heck of a lot. And they've actually said that, being at home and by themselves has not really affected them greatly. Whereas other individuals that were more gregarious in nature, that's actually created a great degree of difficulty. Being constrained at home can be a difficult thing, but also following through with recommendations. When we try to educate our patients about how to be well, it's not just about tossing pills their way. It's about, really changing the entire sphere of their lives and their makeup. How much fluid they're drinking and what type of fluid. If you can just please drink water instead of soda, if you can read the right foods and, again, portion control, if you can set yourself in such a regimen that you're sleeping the right amount of hours for you and that you are exercising so that physically and mentally you're spent, and by the time that your head hits the pillow, you're going to be feeling well, are not rocket scientry, but they're not necessarily adopted by a lot of our patients. When we deal with tardive dyskinesia, we obviously know we have solutions. We have 2 agents that are FDA approved, VMAT2 inhibitors, that are the way to go in treating tardive dyskinesia once we've recognized it, and then maximizing on the treatment for individuals, because ultimately we're always treating folks to the extent of maximizing as much as we can out of the intervention. One way in which we can gauge whether that happens is to have family members reflect on, the movements that the individual may have began with and how they're doing. So I'll oftentimes not just ask a patient, have you noticed a difference? And I'm observing the difference in them, but I'm also getting the feel of their loved ones or their associates or family members or friends that are around that individual that I then subsequently have an opportunity of linking with in a remote visit. And in that way, I can figure out whether we're maximizing on whatever it is that we're utilizing for that particular patient. Reminding them that, when they're stressed out, and certainly these are times of uncertainty, people just don't know what to do. I'll give you an example here in California. The governor just basically shut down the state again, because there was an additional spike of cases of COVID. It's a very serious situation, I understand, but it also creates a lot of uncertainty in people. And that increase in stress and anxiety can oftentimes make movements of tardive dyskinesia worse. So we obviously then have to take into consideration the circumstances around that individual and understand that there may be variations in the presentation of the condition.
I can't thank you enough for joining us today, Gus, to talk about the top 3 challenges with providing care to patients with or at risk for developing tardive during this pandemic. But before we end, would you be so kind as to summarize your top 3 takeaways based on our conversation today?
You bet, Sandra. I'd be happy to. I think the main 3 takeaways would be, 1, technology shouldn't be scary. So if we've had to shift from, seeing someone physically to more of a remote encounter, that's okay. It's not a reason by which not to diagnose or, again, treat someone and then follow through with, say, a condition like tardive dyskinesia, which has been the discussion piece. Number 2, I would say that when we can employ other people and maybe utilize the pretext that if you're going to have difficulty with the instruments that are being utilized, whether it be a computer or a tablet, maybe someone that can help out with that could create a nice linkage in facilitating having someone else, an informant, that can give us additional information as to the circumstance of that particular patient, and then subsequently follow up with someone better. And number 3, I think that we've seen multiple examples of where we can facilitate and continue to join our patients with solutions. In the case of tardive dyskinesia, VMAT2 inhibitors are the indicated way to go. And then being able to track someone in again, a filtered fashion in which through a screen, we're able to have nice close scrutiny as to whether our interventions are being successful and trying to get that individual to the best dosing possible where they should be. And in addition to that, having specific measures in place, including, maybe other individuals, family members, friends, associates, giving us some information as to how the person's doing aside from what we're observing, and then linking in different services for people in such a way that even in face of a pandemic like what we're seeing right now, we can actually create a greater ease so that individuals can follow through with the recommendations that we're making for them and keep them healthy.
Well, many thanks, Gus. Those are really valuable takeaways from our conversation today. And let me end by saying that we hope everyone stays healthy and well. Goodbye for now.
Thank you so much. So long.